So with that being said, I'm very happy to talk about this topic of thermography and breast cancer screening, as well as in breast cancer diagnosis, because I think it is imperative that we all be equipped with the information to be able to understand the limitations of thermography and what really is the best evidence that supports why in the world we do screening mammography, and why I firmly believe that this is within the realm of possibility for India, just as it is in many other developing countries like Brazil and African countries. So I'm hoping that you will have a better sense of what the limitations are of thermography and what the comparative screening programs are able to offer. So without saying anything more, let's go to the next slide. So I want to start by giving you a bit of history of thermography. And it was started in or developed and invented actually by a Canadian surgeon, Dr. Ray Lawson, in Montreal at McGill, where I went to medical school. And he invented this because he was looking for a technique to identify early cancer in the breast, because he was, as a surgeon, seeing the limitations of seeing advanced cancers. Unfortunately, he learned through the next years of his career that thermography was not clinically useful. And he actually never used it alone without using it with ultrasound and mammography. There were subsequent large trials, multi-center prospective trials conducted between 1974 and 1981 that looked at thermography, and in a study of over 16,000 women, comparing with mammography, there was a sensitivity of thermography that was only 39% and a specificity of 82%. So both Dr. Feig as well as Dr. Lawson concluded that thermography was not a viable screening tool. And late in 2017, there was an article published about the history of thermography about Dr. Lawson, and a comment was written by the Sun, really trying to correct the point that although he had pioneered thermography, he recognized its limitations very early on and then used it very responsively just as an adjunctive tool with other tools, and relied very heavily on ultrasound and mammography. And so he really had identified the potential of ultrasound as the best tool for detection of cancer without mammography. So let's talk about the physics. And this is really important to understand how thermography works. It measures the surface temperature. And so if you look at this diagram, it will perceive anything that generates excessive heat in the superficial 1.5 centimeters of breast tissue, which is identified by this blue line. So when you look at a cancer that is close to the skin surface, it will often generate excessive heat by the increased vascularity, and so it can be detected by a thermogram. Similarly, a benign tumor like a fibroadenoma or an inflammatory cyst that is close to the skin's surface will also generate excessive heat and be detected as a positive on thermogram. So what happens is the ones that are deeper in the breast, the cancers that are even large or small, that are below the threshold of the surface temperature rise, will not be detected, and nor will the benign lesions. So only the ones that are closest to the surface of the skin will be detected. So the deeper malignant lesions will not be seen in the breast unless they're so large that they induce growth of significant vessels that are appearing at the surface of the breast. And I'll show some examples at the end where a thermogram would be positive, but it would be very extensive disease where we detect it. So for cancer to be detected by thermogram, it must be large, it has to generate a lot of heat, and it has to be close to the skin surface. Now, one analogy that was provided to me by Dr. Kopans, who's a professor of radiology at Harvard Medical School, is really to think about thermography and insulation. And in Canada, where we have very cold winters, this is used quite extensively to look for heat loss in a house. So what happens is the in-house inspector will point the thermogram at the house to identify where there are sources of heat loss. And in this middle picture, you can see that there is a great deal of heat loss from this roof and from this door. And that would tell the inspectors that there's a need for better insulation to seal off that heat loss. But you'll notice that the chimney in this house does not have any heat loss. And even with a fire in the chimney, because the house is well insulated, there will be no perceived heat loss. And so what happens if you think of a breast, the heat loss generated from a cancer will be detected if it's at the surface, close to the surface where there's no insulation. But anything deeper where it's insulated by fat and breast tissue will not be perceived, similarly to a chimney or a fire in a chimney. So this is one of the limitations of the thermogram. So it lacks sensitivity because of the generation of heat by the increased metabolism and vascularity that doesn't occur in small tumors. It has to leak out of the breast in order to be detected, and there's signal loss and spatial resolution issues. And it lacks specificity because anything that is inflammatory will increase the temperatures. And as Dr. Yaffe, who is a professor of physics at the University of Toronto, said, it has never been evaluated in a properly designed or powered clinical trial. So if we look at this New Zealand Health Technology Assessment published in 2004, they looked at all the studies of thermography and found that the cancer detection rate ranged between 42 and 80%, and compared with mammography was almost half, where mammography detected 82 to 93% of cancers. And we know that this is true for all breast tissue densities. We know it's slightly higher with mammography, with low dense, non-dense breast tissue, and lower with dense breast tissue. But on average, in all studies, the sensitivity of mammography is about 85 to 90%. And on the other hand, the false positive rate for thermography is 25%. And if we think of screening mammograms, typically less than 10% false positive rate, the false positive rate for thermography is more than twice that of mammography. And we have patients who have inflammatory changes, infection, lactation, and pregnancy, particularly in our younger group of women. And this will increase the temperature of the breast and lead to many more false positives. So this health technology assessment also concluded there was no value in thermography for early detection of cancer. And as I said, the false positives of thermography, which we see as radiologists, as surgeons, is that we see a lot of fibroadenomas, inflamed cysts, and even elevated body temperature. And the method of doing thermography is quite significant. You have to have the woman in a cold room for a certain amount of time. And if they have any increased body temperature, this will lead to a false positive. So because of a lot of centers that were offering thermography without regulation, the Federal Food and Drug Administration of the United States established a warning in 2019 saying that there's no scientific evidence to show that thermography devices used on their own or with another diagnostic test are an effective screening tool for any medical condition, including early detection of breast cancer. And they have this illustration to show the limitations of thermography as compared to mammography. This is still an ongoing problem, and they issued another warning in 2021, again reiterating that thermography should not be used to replace mammography. I will say that in Canada, Health Canada also has a very similar warning, and that says that it really should not be used. So these are very well documented and researched agencies that have looked at the literature and concluded, as I've shown you already. So then I think it's important to look at this study. And this study from Niramai was published in the journal Global Oncology in 2019. And it was called an observational study to evaluate the clinical efficacy of thermolytics for detecting breast cancer in symptomatic and asymptomatic women. And this is an illustration from their article. It's very important to note that all of the authors had disclosure of conflict of interest, and all of them were either employed by or funded by Niramai Health Analytics. So none of the authors had no conflict of interest, and they were all funded by this company. What they did is they took 587 women recruited at 2 sites in Bangalore between 2016 and 2019, 18 years and older. They provided informed consent to be imaged with thermolytics. They used 102 to establish a deep learning tool using artificial intelligence using this infrared thermography. So the same technique, but using infrared thermography, but applying an artificial intelligence detection to help with the detection method. And they had 3 different models. Now, these are the results that were provided in the study, and you can see that there were 470 women included. Only 50% underwent mammography, and not all women underwent ultrasound. And the total number of malignancies was very high, 78 out of 470. Now, these are the reported sensitivity and specificity, but as I'll show you, this is really it's not this does not agree with how they reported it. So let's go to the methods. So there were 127 women who were under 40 years of age, so a third or a quarter, and 343 who were 40 years and older. So 470 women in total where they could use the results. And the problem is that they did not apply a reference standard. So what I mean by a reference standard is that there has to be a baseline truth. So if you screen a number of women, you have to either have like the gold standard being, all women having breast MRI or all women having the highest sensitivity test to detect whether there's cancer. And if you don't apply that, you need to have a follow-up of at least 2 years to determine whether or not they developed cancer. And so what happened is in this study, women who are 40 years and older were referred for mammography or ultrasound or both based on the radiologist's preference. And so not all patients underwent even any breast imaging at all. They only did the thermolytics. And the women under 40 only were referred for ultrasound. And in fact, not all of them underwent ultrasound either. They said that suspicious findings were biopsied with either fine needle aspiration or biopsy, but in fact, not all patients with suspicious findings were biopsied. And then they compared the rates of BI-RADS 4 or 5 by mammography or ultrasound if they were done, and biopsy positive for cancer if it was done. So this was used only if it was done. So there wasn't a standard applied to all women. And as I said, any test that is evaluated for diagnostic accuracy has to have a reference standard. And so most diagnostic studies would always apply a minimum follow-up of 2 years, but that was not done in this case, and no breast MRI was done. So when we look at the results, patients were categorized as symptomatic if they had a breast lump, pain, nipple discharge, nipple inversion, or skin changes in the breast. And of this population that was studied, 50.6% of women were symptomatic, and half of them were asymptomatic with a lump. There were only 232 or 49% of women who were asymptomatic that you can consider as being screened. So if we look at the women under the age of 40 who were supposed to have ultrasound, there were 127 who were studied, and 1 did not undergo ultrasound. And of these, 52 were asymptomatic, and 33 were positive with thermography. So there was a positive rate of 26%, of which 11 were cancer. So in fact, 22 false positives in this group. So a high number of false positives. If we look at the women who were 40 years and older, there were 343 women, and of those, 180 were asymptomatic. The ones that of all, 31% were positive, and so that was a high number. And in fact, it was a high false positive rate as well, but 60 were cancer. So I think what you're seeing is that a lot of women had cancer in this population. And if we look at the patients who underwent mammography, only 11 in the women under 40, and of those, or over half were positive. So these were a highly selected symptomatic with cancers. And similarly, 11 out of the 13 women who underwent ultrasound under the age of 40 were positive and were cancer. So if we compare the women over 40, there were also a third were positive with thermography. But if we look at those that had mammography, only 43 out of 49, or 88%, had mammography and were positive with mammography, as compared to 67 out of 69 were positive with ultrasound. Now, it's really helpful to look at the context of this. And normally, when we have a biopsy rate of between 20 and 50%, that's the range that we expect. So when we say we're going to do a biopsy based on an abnormal finding on mammography or ultrasound, we expect it to be within that range, not over 50%. But in fact, here you can see it was 88% with mammography and 97% with ultrasound. So this is a very, very selective group of patients who were almost certainly going to have cancer. And so the rate of cancer amongst these patients was over 50% in the symptomatic. And so this is really quite a biased kind of group that we're looking at. So it's really important to look at that in the context of the results. So as I said, many women did not undergo mammography, and especially if we're looking at the women over 40, where we should be doing mammography, that's the recommendation, that anyone goes for mammography if they're 40 years and older, especially for screening, but especially if they have a symptom. And we see that 43% of them did not undergo mammography. And there were 11 women who did not undergo ultrasound. The other point which I made was that there was no follow-up, but also importantly is that there were clinically suspicious findings by the surgeon, and several of them did not undergo any kind of validation. And so 7 of these are potentially false negatives, and 3 of them were never validated. So this is really again, a limitation. And in most studies, these cases would simply be excluded from the analysis, but this was not done. And then if we look specifically at the asymptomatic women who would we be considering screened, there were only 232 women, but only 95 of those had both mammography and thermography. So it's a very, very small group. And of this group, 4 cancers were detected. So that would equate to 42 per 1,000 as a cancer detection rate, which puts you into a very high risk category. Just by context, when we look at our high risk population with a lifetime risk of 25% or greater, we expect only 20 per 1,000. So this is twice that. So it's very, very high numbers of cancers. We don't have any details about the cancers that were provided. The report says that 2 cancers were missed on mammography, but there was no information about the type of cancer, the size of cancer, or their density. And we know that mammogram may miss cancers when they're very dense. And the fact that there was no reference standard, we don't know how many cancers were missed in those women who did not undergo mammography, or who were missed on both mammography and thermography that would have been picked up at 2 years. So these are the limitations that I think it's very good for you to be aware of. So the conclusions that the sensitivity of 91% is really not valid because we don't have a reference standard, and any report of sensitivity has to have a reference standard to provide a sensitivity. So the conclusion that the authors said that this could be a potential primary screening method for breast cancer, given the literature and the small sample size and the lack of reference standard, we just don't have it supported by the evidence. So I'm going to stop the description of this study, and I thought it would be useful to give you an idea of some of the other literature that really has been extremely well validated to show the benefit of screening mammography. And I know that some of the proponents of thermography would be saying that, well, there's no radiation, you don't have to have your breast assessed or touched. But I think most important to patients is the benefit of overall survival and breast cancer reduction. And I think it's shown very well by the implementation of breast cancer screening in Canada. So the graph on the left is the incidence of breast cancer in Canada between 1949 and 1996. And what we saw in breast cancer in that time period is a rising incidence of breast cancer over that 40, 50-year period, which we know has occurred around the world. And what we saw was in the mortality, or the incidence has remained stable since about 2001, where we have a stable incidence of breast cancer. So in rising incidence and then stabilizing in the last 30 years. But look what happened to mortality. So mortality from breast cancer in Canada was a completely flat line as compared to improvements in treatment with colorectal, ovarian, and even cervical cancer. Lung cancer mortality really steadily increased over that time. And then look what happened when we started breast cancer screening in 1989, where we adopted population-based programs across the country, and the mortality of breast cancer dropped incredibly by almost 50% since 1989. And that was really attributable to when we started screening mammography in 1989. And this has been seen around the world in countries where screening mammography was adopted. And if we look at a very large study of over 2.8 million women in Canada, looking at women who were screened as compared to those who were not screened after 20 years of screening, you can see that there was an overall reduction in breast cancer mortality of 40%. It varied across the provinces, and in Ontario it was about 30%. It depended on where you lived, but overall, this was a very, very significant reduction in breast cancer mortality. And if you look at the age groups, there was a significant reduction for women in their 40s as it was in their 50s, 60s, and 70s. So it was across the ages that we screen. This has been reproduced by many other observational trials, and this is from a meta-analysis published by Dr. Coldman et al. And you can see that overall, there's a 50% reduction in breast cancer mortality when women are screened with mammography, and that's for all ages from 40 to 74. So a recent study, actually prospective study, published in the Journal of Radiology just last year, of over 500,000 women ages 40 to 69, found that women who were screened every 1 to 2 years had the best reduction in breast cancer mortality, shown by the green bars here. And women who were what we call serial non-participants, those who did not participate in screening mammography, had the lowest reduction. And they calculated this reduction so you can see that there was a 50% reduction in breast cancer mortality by screening mammography in this long-term, very large prospective trial. This is not due to causing breast cancer. This is due to reduction of breast cancer mortality from mammography. And so we know this from multiple studies that we reduce the breast cancer mortality by at least 30%. And all-cause mortality is sometimes used as a reason not to screen. But the problem is that many women don't die from breast cancer. Only 3% of the deaths in the general population are due to breast cancer. So by reducing breast cancer mortality, you only reduce all-cause mortality by 1%. So you would have to do a very large trial of women in a randomized controlled trial to show this as a reduction. And in 2022, this is considered unethical to do any other studies of this size. And so we really rely on these large randomized controlled trials and observational trials to show that it does benefit. Now, I mentioned earlier that thermography does identify cancers, and this would be a case where we would clearly see a positive thermogram. And what we see in this patient, but for all of us as radiologists, we would easily recognize this as a very advanced breast cancer. So this was a 43-year-old woman who had a right breast lump. And you can see that there's a very large mass in her breast. There's marked skin thickening. She also has lymphadenopathy that is metastatic. And this was proven to be a large invasive ductal carcinoma. She was never screened with mammography. She was simply came with a presentation of a right breast lump. Now, this is another woman who wanted to be screened, but was refused. And this, she presented with a 3-month history of a left breast lump. And you can see the mass in the axillary tail of the left breast and the adenopathy. And you can see that on ultrasound, there is a spiculated mass with these small calcifications within it. Very suspicious. Very likely this would be positive on thermogram as well, because it's very close to the skin surface. But we're not relying on early detection in this case. We really want to detect it earlier. And I want to show you this example of a woman having screening mammograms every 2 years. She has a small cancer in her breast. It's spiculated. And you can see there are no vessels that are increased. It's deep to the skin surface. This would not be picked up on a thermogram, but it's very, very easily detected on a screening mammogram. And so she benefits from an early stage diagnosis of breast cancer with 100% 5-year breast cancer survival. So this is what we are aiming for with our screening mammography programs. So the benefits of early stage diagnosis is that survival is almost 100% at 5 years. The treatment is less intensive, and the duration of treatment is much, much lower. So treatment duration is usually half for an early stage as opposed to a late stage, which has a survival that is between 28 and 60%. We know that it results in higher therapy costs, more chemotherapy, more likely to have mastectomy, axillary lymph node dissection, and radiation, and often treatment can last for a year. So to patients, our patients, these are very significant downsides of late stage diagnosis. So we aim to screen women for breast cancer because of early detection. And with our screening programs, we monitor the sizes of tumors, and we should have at least 70% being less than 1.5 centimeters. We know that it leads to fewer axillary lymph node metastases and less likely to have the complication of swelling of the arm from lymphedema. We also know it leads to lower costs of treatment with less extensive treatments, surgery, time off work, and greater satisfaction of patients who are feel more comfortable when they have their entire breast or only breast conservation surgery. And so this really are some of the benefits that we have to consider when we're looking at screening. So I've given an overview of what the limitations of this study are based on a very large number of women who are symptomatic. There's no reference standard of follow-up or conventional imaging to compare in the majority of their patients, and it was a very small sample size. We know that the limitations of thermography are really based on the physics of this, which then lead to high numbers of false positives and a high number of false negatives. And I think for our patients, and the reason we want to promote screening is that we want to be as accurate as we can, using the lowest cost available, which is really mammography. And this is what we should aim for. We don't have any large trials to show benefit from thermography, while we have very extensive evidence to support the use of screening mammography for early detection of breast cancer. So with that, I really want to thank you for your attention, and happy to turn it over to the discussion, as I'm sure there will be good discussion points. Thanks.